Good morning, everyone. Today's seminar is about disorders of intestinal fixation and rotation. It will be presented by me and Dr. Srilakshmi. Objective of the class are how a gut normally rotates and fixates, classification of abnormalities of intestinal rotation, clinical manifestation and experimentations, how it can be radiologically diagnosed, what is the management of the malrotation, what is the role of minimally invasive surgery, and how the post-operative outcome present to us. In embryology, we will first see the normal rotation and fixation of the gut. It happens in the four steps. First is herniation, second rotation, then retraction, and then fixation. However, rotation happens during herniation and retraction as well. And there are two components of the midgut that rotates around the superior mesenteric artery. First one is the proximal loop or duodenojejunal loop, and second is distal cecocolic loop. To see the rotation of duodenojejunal loop, it initially is above the superior mesenteric artery. Then it first rotates to the right of the superior mesenteric artery, after which it goes to the below the superior mesenteric artery, and then it goes around and it goes towards the left of the superior mesenteric artery. Finally, in adults, adults of the child, the position of the superior mesenteric artery is related to the stomach and the duodenum, like this. The stomach is above the artery. Second portion of duodenum is to the right of the artery. Third portion of duodenum is beneath the artery, and the fourth portion, which is distal duodenum, and the jejunum is toward the left of the artery. The second loop, cecocolic loop, it initially beneath the superior mesenteric artery. After which it goes, rotates and goes towards the left of the superior mesenteric artery. Then it turns again and goes above the superior mesenteric artery, and it again turns and goes towards the right of the superior mesenteric artery. Both of these rotation happens in counterclockwise direction and at 270 degree. Both of the rotation happens simultaneously. The final position of cecocolic loop is towards the right side of the abdomen. Terminal ileum, cecum, and the right colon lies. It happened, the timeline of this is from 4th week to 12th week. At 4th week, the physiological umbilical herniation occurs, after which till 10th week, the herniation persists, after which the gut retracts and comes up inside the abdomen at 10th to 12th week. After which the mesentery fuses and fixate the ascending and descending colon. Through the herniation, the first part that retracts back is the small bowel, including duodenum and jejunum, and the last part that retracts is cecum and the right colon. Here's the video that that illustrates how the midgut rotates.
Rotation of the midgut happens during the second
at the 4th week of the life, the midgut is the gut is a straight line. Then it connects to the vitello intestine duct, and then these are three parts: foregut, hindgut, and midgut. The foregut is supplied by superior.
yolk stalk, which later becomes obliterated.
The foregut is supplied by celiac artery, the midgut is supplied by superior mesenteric, and the hindgut is supplied by inferior mesenteric artery. At 4th week, the midgut starts to expand and herniate into the umbilicus. And there are two parts. The first part is this part. This is duodenojejunal loop, and the below part is cecocolic loop. During the first herniation, it turns to the 90 degree, and the duodenum lies to the right, and the cecocolic loop lies to the left of the artery. At 6 weeks, the cecal bud appears, and after which the duodenum and the proximal loop expand, and the distal loop also expands. At around 8th week, the second rotation in the duodenojejunal loop occurs, and again rotates to a 90 degree. However, there is no rotation in the cecocolic loop. After which the gut starts to retract. First, the small bowel retracts, and after which, and it also during retraction, after retraction, it again turns to the 90 degree. And after which the small colon and the cecum retracts, and it after rotation it completely rotates by 180 degree, so that the colon lies in the front of the duodenum. Here the another angle of this illustration. So the gut herniate at the fourth week of the life, after which it rotates to the 90 degree. Then the appearance of the cecal bud and the small valves start to expand. And as the abdominal cavity expands, this gut retracts back, but the small valve will retract and rotates to 90 degree more. After which the large valve will come back and it retracts to 180 degree. After this retraction, the duodenum will lie behind the transverse colon.
One word, I mean, there is a 370 degree counterclockwise rotation, but I think all the diagrams do a little disservice, right? It basically tells that everything is rotating. So in effect, the mesentery power also will get volvulus intra-uterine. Actually, each loop is individually rotating around the axis rather than the whole thing rotating. So for simplicity, they rotate the whole thing, but each loop is individually rotating around the superior SMA axis. The SMA axis remains actually straight.
As the other one's contribution in this subject, where much better illustrations are shown. Your senior colleague has drawn all the diagrams by himself in a better way, and they're quite colorful. Maybe you have seen that chapter, and it shows much better than the diagram which you are showing the diagram. I'll share it later.
So at the fourth week of life, the gut herniates and there is appearance of cecal bud. Along with this, the gut herniates to first rotates to first 90 degree. The second rotation happens when the gut retracts back, and after the third rotation happens. After the third rotation happens, the cecum is appear just below the liver in right upper quadrant. As the colon starts to expand, it comes below and fixates into right inguinal fossa, right iliac fossa, and fixate there. After which the mesentery of right ascending and descending colon along with the mesentery of duodenum will goes retroperitoneally and fixate there. The classification of intestinal abnormalities of intestinal malrotation. There are three types of malrotation that are described. First is non-rotation, second is incomplete rotation, and third is reverse rotation. In non-rotation, there neither the gut or the colonic loop will undergo rotation, and the colon and the cecum and the colon will lie in the left side of the superior mesenteric artery, and the duodenum will lie towards the right side of the superior mesenteric artery. In incomplete rotation, the rotation of 180 degree will happen. In that way, the cecum will be in epigastrium overlaying the third part of duodenum. These are the most commonly surgically treated malrotation. And the third is reverse rotation, in which the reverse rotation of 90 degree will happen, so that the DJ loop will come anterior to the superior mesenteric artery, and the transverse column will lie posterior to the SMA. In these, the SMA can cause obstruction of colon. These abnormalities in the gut rotation are associated with other things like intestinal atresia, imperforate anus, cardiac abnormalities, duodenal web, macula diverticulum, and trisomy 21 and hernias. And these are also associated with mesenteric cyst, biliary atresia, Ashwang disease, but those associations are quite rare. The clinical manifestation will be presented by Dr. Chulu.
Now, coming to the clinical manifestation of intestinal disorders of intestinal fixation and rotation, they have a very varied presentation and can vary. The presentation can happen at the neonatal age group to the adult as well. So the incidence of malrotation or non-rotation is found to be around 1 in 500 live births, and 2/3 of them present will in the neonatal period itself. They are associated with many gastrointestinal anomalies as discussed earlier, and along with that, the malrotation is known to occur in the diseases like omphalocele and CDH. So volvulus occurs less frequently in the patients with malrotation. However, the incidence is quite high, as much as 14%. And volvulus sometimes can occur in utero, and these patients can present with the features of intestinal atresia because of the vascular insult. They have a variable presentation So the presentation can vary from chronic abdominal pain to acute manifestations like a midgut volvulus. So similarly, the symptoms can be acute or chronic, and sometimes even the recurrent symptoms can be there. And bilious vomiting is a hallmark of the malrotation and midgut volvulus. So in the older children who present at a later age group, they usually present with intermittent episodes of non-bilious vomiting, and there will be failure to thrive because of the reduced weight gain, and there can present complaints of recurrent abdominal pain. So in the physical examination, they will be having a totally normal, complete abdominal picture in 50% of the patients, even when they're present in the neonatal age group without the volvulus. So the next most common sign is the distension without any tenderness because of the malrotation. If the patient present with the midgut volvulus, these patient can progress to shock and peritonitis, where there will be abdominal features of the same, and and eventually they will go for infarction if not intervened at the earliest. So a high index of suspicion has to be kept when we are evaluating a child with signs and symptoms of small bowel obstruction. The possibility of malrotation should always be ruled out. Coming to the acute midgut volvulus. So patients of malrotation have a high predisposition to develop acute midgut volvulus, especially the patients who are having uh, no, in these patients, there will be narrow pedicle, which will be formed by the base of the mesentery. So this narrow pedicle can twist clockwise from the duodenum until the transverse colon, which can lead to the midgut volvulus. So that there will be excessive length of the mesentery or a point of adhesion at the convexity of the loop, which can act as an axis around which the bowel will twist. There is no such inciting mechanism which can cause this. However, some of the possibilities include the abnormal intestinal peristalsis, or if there is any segmental bowel distension or unusual movement of the torso. As we can see here, in the patients where there is non-rotation or in the patients with the malrotation, there will be having a shorter mesenteric pedicle, the narrow pedicle around which the volvulus can occur, and they will be present with acute midgut volvulus. So they use majority of them, as much as 80% of the patients will present in the first month of the life whenever they have a volvulus. And the presentation usually includes a sudden onset of bilious vomiting, and there will be crampy abdominal pain. Sometimes there can be bleeding per rectum whenever there is infarction of the bowel. And there can be complete obstruction rapidly develop into the intestinal ischemia, and they can develop with a firm distended abdomen with features of peritonitis and shock. So the diagnosis mainly involves in the history and clinical examination, and some because of the bowel ischemia, these patients will have metabolic acidosis. And radiological investigations such as X-ray and USG can help us in coming to the diagnosis. Coming to the chronic volvulus, these patients will be present in the later age group, that is more than 2 years of age, and they usually present with intermittent partial midgut volvulus, and which results in the chronic lymphatic and venous obstruction, which can lead to the mesenteric lymphadenopathy. So this will lead to these patients will have protein calorie malnutrition because of the chronic lymphatic and venous obstruction, which will lead to the malabsorption. So they will present with the complaints of chronic vomiting, recurrent episodes of non-bilious vomiting, and recurrent abdominal pain and failure to gain weight. Coming to the acute duodenal obstruction secondary to the congenital bands. So these are more common in the, this presentation is more common in infants and neonates, and there will be usually a peritoneal bands which are called as Lad's band, which extend across the third part of the duodenum from the cecum or the colon, right side of the colon to the peritoneum, peritoneum. So these cause an extrinsic compression on the duodenum, and which will lead to the kinking of the bowel and present with the features of obstruction. So they usually present with the features of proposal bilious vomiting with or without any abdominal distension, since the obstruction is proximal. And they will have, sometimes they can be visible gastric peristalsis as well, and often associated with the intrinsic duodenal obstruction in the form of duodenal web as well. So sometimes whenever there is a extrinsic obstruction to the third part of the duodenum, they can even present with a double bubble appearance as well. Coming to the chronic duodenal obstruction, because of this same congenital bands. So this presentation usually is in the later age group, that is infancy to preschool age, and they usually present with the bilious vomiting, and again the failure to gain weight will be there, and intermittent colicky abdominal pain will be there. So contrast study must be performed very carefully, because the degree of the enlargement of the duodenum is very subtle in these patients, and which can be missed if not done properly. Sometimes the malrotation can be found incidentally in a patients who are asymptomatic or minimally symptomatic patients. So it can happen during the evaluation of patients for chronic abdominal pain or at the time of any other operation. So this always raises a dilemma whether to operate for the malrotation or not. But whenever there is a typical malrotation, that is the DJ is present in towards the right side of the spine, and there is a cecum is present in the subhepatic region, and they have a Latz band. This corrective procedure has to be done, because there is always a risk of development of volvulus in the patients who have typical malrotation. Coming to the reverse rotation, these reverse rotation patients, as we discussed earlier, these patients will have the duodenal loop, which is present anterior to the transverse colon, and in the SMA will be in between. So these patients will present with the chronic colonic obstruction, but the presentation is usually delayed, and they present in the adult age group. So this leads to the complete chronic incomplete or complete obstruction of the colon, and that is seen in the adults, as we discussed. So coming to the internal hernia, so another presentation of malrotation can be in the form of internal hernia, as was described by Wilbert and colleagues. So there will be lack of fixation of the mesentery to the right and left side of the colon and duodenum. So this results in the formation of a potential spaces through which the small bowel can herniate and present with the internal hernia and features of obstruction. There will be recurrent entrapment of the bowel with partial obstruction, and they can eventually progress to the complete obstruction and strangulation of the bowel. So in the right mesocolic hernia, there will be prearterial limb which fails to rotate. The prearterial limb of the small colon, bowel fails to rotate around the superior mesenteric artery, and these bowels will get trapped by the mesentery of the cecum and the colon. In the left mesocolic hernia, we have to see that here the small bowel is rotating normally, and there is no incomplete rotation. Here, the unsupported area of the descending mesocolon between the inferior mesenteric vein and the posterior parietal colonic attachment will be ballooned out, where there will be herniation of the small intestine. So here, in the patients who present with the mesocolic hernia, they will have the normal position of the cecum, and it will be present in the right lower quadrant, and the ileum will be existing they will exit from the sac of the mesocolons. As you can see in this picture, the first image is a demonstration of the right mesocolic hernia, where there will be herniation of the small bowel through the right side mesocolon. And here we can see that this is a left mesocolic hernia, where there will be herniation of the small bowel along the left mesocolon. They usually present with the chronic complaints. There will be recurrent episodes of abdominal pain, and there will be bouts of symptoms of intestinal obstruction, and they will be having recurrent colicky pain. So the radiographic picture, which is obtained only at the time of the attack of the pain, can demonstrate the features of obstruction. Coming to the volvulus of the cecum, again, this is a presentation which occurs in the later in the age group. They are usually seen in the adults who are aged more than 60 years. So this is due to the lack of fixation of the cecum and the terminal ileum and proximal ascending colon. So they will present with the features of obstruction, where there will be severe acute abdominal pain and vomiting will be there, and the X-ray image will be demonstrating a distended cecum, which is directed towards the left upper quadrant. Coming to the radiological diagnosis of the abnormal rotation and fixation. Usually the radiological diagnosis is not very conclusive of the malrotation, and whenever in doubt, the patient has to be operated. Coming to some of the others. Sorry.
Saying radiological diagnosis is not like malrotation, and that
So whenever as in whenever the radiological investigations are not conclusive, because sometimes there is a high chances of missing the malrotation in the
brain radiograph is not diagnostic. Don't say radiological investigations are not. मैं ऐसे मतलब बिल्कुल blindly नहीं बोलना है कुछ. See what you are talking about.
So whenever there is extensive obstruction to the duodenum, they can present with the proximal dilatation of the stomach and the duodenum, with or without any. There can be and there can be appearance of a double bubble appearance whenever there is acute duodenal obstruction. However, volvulus of the midgut can present with the in the X-ray. We can appreciate gaseous abdomen. Coming to the ultrasound, the screening of the infants who are having the suspicion of midgut volvulus has to be done with the ultrasound. And here there can be, we can demonstrate, we can appreciate the whirlpool flow pattern of the SMB, and the mesentery around the SMA axis can be seen whenever there is a patient presenting with the midgut volvulus. So additional findings which can be demonstrated in these patients includes fluid-filled distended and dilated duodenum along with the thick bubble loops which are located to the right side of the spine because of the malrotation. Coming to the one of the other feature of the which can be appreciated if the ultrasound is done appropriately is that during the rotation, this position of the so we can make use of the position of the duodenum and SMA, and we can evaluate that in the patient suspicious of who are having suspicion of the volvulus and malrotation. So the normal position includes the third part of the duodenum should lie resume the retroperitoneal position, and anterior to that will be the SMA, and posterior to that will be the aorta, as we can appreciate in this. The third part of the duodenum is here, and behind that will be the aorta, and anterior to that will be the SMA. So verification of this position obviates the need for the further imaging. Coming to the upper GI contrast study, sorry, sir.
It is not there. If the malrotation is there, then what is that?
So, in patients with the reverse rotation, this position will be altered, sir.
No.
In the patients who are having reverse rotation, the position of the duodenum will be anterior to the transverse column.
Transperitoneal, intraperitoneal transverse duodenum.
Yes, in the reverse patients with reverse rotation.
Transverse duodenum.
The verification of from this position obviates further imaging. How many patients they have done with this training?
I don't remember exact number.
Address things, now that we have audience. You know, currently we are studying ultrasound that is good.
I'll check
So
the
it's
number.
substantial evidence to say something like this. There's a new study which is claiming this. But the numbers are this much, and further work in this area has to be done. This is what we talk. We cannot say like the verification of this potential. What is the gold standard?
Upper GI contrast study is the question.
Can you discuss one? Few articles are there on this. Modular cases nahi hai.
Now coming to the upper GI contrast study, this is a preferred study for understanding the abnormalities of the intestinal rotation. So this assesses the position of the ligament of treats relative to the midline and the center related to the midline or the center of the vertebral body, and we have to correlate that with the level of the gastric outline. However, before proceeding to the upper GI contrast study, peritonitis has to be ruled out, and there has to be the upper GI contrast study shouldn't be carried out if there is features of peritonitis. So the normal finding, as we can appreciate in this picture as well, is that the ligament of treats, that is the duodenal jejunal flexure. So this will be at the level, it will be present towards the left side of the vertebral body, and will be present at the level of the gastric outlet. So in the patients who are presenting with a typical malrotation, the position of the ligament of treats will be towards the right side of the midline. However, there can be presentation with the atypical malrotation where there will be the position of this ligament of treats will be towards the midline or to the left, but below the level of the gastric outlet. So the patient operating the patients with this atypical malrotation can be a dilemma depending on the symptoms of the patient. So in this contrast study, this is the stomach which is distended, sir, and this will be the gastric outlet. So the first, this will be the first part of the duodenum, second part of the duodenum, third part of the duodenum, and this will be the DJ flexure. So this DJ flexure should be towards the right side of the midline, sorry, towards the left side of the midline normally. So this is the midline which we can appreciate the vertebral body. This, the spine, vertebral body.
There is the reason.
Yes, towards the left side. Towards the left side of the midline.
The normal study.
This is a normal size.
Both components are there. It has to be left and right, left of the midline, plus it has to rise up.
Rise up towards the level of the gastric outlet.
Both
So this. So in the patients who are having the features of malrotation, there can be obstruction of the second or the third portion of the duodenum whenever there is extrinsic obstruction because of the peritoneal bands. So this can give the appearance of the bird corkscrew appearance. So here the proximal part of the jejunum will be located on the right side because of the malrotation. And if we follow this patient through the barium follow through, the cecal position can also be appreciated, which will be usually the normal position of the cecum is the right lower quadrant, which we all know. In the patients with malrotation, there can be these patients can have the position of the cecum can be towards the right upper quadrant as well. So as we can see in this study, here this is the gastric outlet. The first part of the
Not is very important. Not if any start with the single position. It can be in the normal position, it can be somewhere higher up also, and if only the cecum is abnormal, that is not diagnostic of malrotation. So cecal position is not given importance when we are trying to diagnose the malrotation. The message out. Normally, we have to neurons operate करते हो, even when they are not having malrotation, invariably you will find the cecum near the liver only. So normally we located नहीं होती है right lower quadrant. Okay.
So the Z sign is another sign which can be appreciated in the contrast study, where there will be sharply angulated to and fro course of the distal duodenum and jejunum, which may cross to the left side of the midline. So this is diagnostic of incomplete rotation and broad peritoneal bands extending across and fixing the involved small intestine without any evidence of volvulus. As we can see here, this is the gastric outlet and the duodenum, the first and the second part of the duodenum. However, the DJ flexure, it is towards the midline, and the jejunal loops, which are not appreciated well in this dye study, but however appears to be on the right side of the spine. Again, the barium enemas in the patients where the upper J contrast study is not conclusive, some of the centers have done a barium enema in these patients where they have found that the cecum and the proximal colon will be in the left flank, or it may cross towards the right side and then angle back towards the left hypochondrium. But however, this cannot be conclusive of the malrotation. Coming to the ultrasound, whenever the radiograph and the upper contrast studies are not conclusive, some of the centers have added other investigations such as the sonography, CT, and MRI for the imaging. However, much time shouldn't be wasted evaluating the patient whenever the patient presents with the acute abdomen with all the other investigations. When coming to the ultrasound, so here the normal position of the superior mesenteric vein is that it is present, it lies ventrally and towards the right side of the SMA. Because and however, if the patient is having the malrotation, the SMA lies immediately anterior to the SMB, which is not the normal position. Even the angiography has been performed in some of the centers whenever the patient present with the suspicions of malrotation. Here, another sign called Barber pole sign. So where there will be whirling of the SMA and its branches, and a tortuous course of the SMB will be there, usually appreciated in the chronic malrotation. So whenever there is complete occlusion of the SMA and SMP with the development of the collaterals, there can be angiographic indications of the vascular compromise, and this is usually present in the chronic malrotation, or it can be present in the chronic volvulus as well. Coming to the management of the patients. So whenever the patient present with the malrotation without volvulus, a rapid resuscitation has to be done before we take the patient to the surgery. So whenever the patient present with the volvulus, a rapid IV fluid resuscitation has to be done with the physiological salt solution. And prolonged resuscitation, however, is not warranted because laparotomy is essential in these patients. So additional measures which we have to take when the patient presents with the volvulus is the placement of an NG, and satisfactory IV access has to be taken, and administration of parenteral antibiotics has to be done before the surgery. Coming to the surgery, operative technique, it has been described by Ladd's procedure within lab in 1936, and this corrects the fundamental abnormalities which is present in the malrotation. So there are a few steps which has to be carried out which are carried out. So one is the evisceration of the bowel, and the inspection of the mesenteric root will be done. Whenever there is volvulus, counterclockwise derotation of the midgut volvulus will be done. The lysis of the Ladd's peritoneal band, and straightening of the duodenum, course of the duodenum, appendectomy, and placement of the cecum in the left lower quadrant. In these patients, we do the exploratory laparotomy, whereas right transverse supraumbilical incision will be given, and it can be extending from the midline towards the laterally. And the incision should be enough to appreciate the entire small bowel and the large bowel. So the two most constant anatomic position, even in the patients with malrotation, includes pylorus and the splenic flexure. So these are the two positions which is not altered in the patient with malrotation. So some of the signs which can point us towards probability of rotational anomaly. This includes abnormal peritoneal bands which extend from the ileum of the right side of the colon towards the parietal peritoneum across the duodenum. So which is the suggestive of the Ladd's band. So there can be fixation of the duodenum or jejunum, upper jejunum, to the cecum or the right colon in the similar way. Visualization of the entire duodenum, particularly the third and the fourth portion of the duodenum at the base of the transverse colon mesentery, and abnormal position as well as the mobility of the cecum or duodenum along the right gutter can also indicate towards the malrotation. Once we open the abdomen, we have to locate the ileocolic junction and orient the ileal mesentery in a way that it lies flat on the surgeon's palm. So the normal position is that the cecum will be lying towards the right of the ileum. So if this position is altered, it indicates that the malrotation is present. So the separate cecum and the right colon, we have to separate the cecum and the right colon at the duodenocolic isthmus, and the narrow mesentery. When we separate this, the narrow mesenteric attachment can become apparent. So coming to the reduction of the volvulus, small bowel appear congested when we open the abdomen. If there is presence of the volvulus, usually the small bowel will be congested or blue, and there can be dilated mesenteric veins as well. The entire small bowel and the large intestine has to be delivered from the peritoneal cavity, and at the same time, we have to ensure that the traction is much of the traction is not given at the mesenteric root. So we have to identify the twist at the base of the mesentery, and whenever there is volvulus, it has to be derotated. The derotation happens in the counterclockwise direction, and usually we have to take a steps of 180-degree turns to until the twist is completely disappears in the mesenteric root. Usually 2 to 3 turns of volvulus can be present when they present to us. So the transverse colon and cecum, transverse colon and the cecum come anterior to the mesenteric pedicle. So this is the pictorial depiction of the same thing. When we open the abdomen, there can be changes of ischemia in the bowel. So when the mesenteric root is inspected, there can be volvulus. So this has to be derotated in the counterclockwise direction. And after that, the peritoneal bands has to be released until the duodenum is straightened. And then we have to place the bowel back in the abdomen. So coming to the releasing of the duodenal obstruction, So this begin at the pyloric or duodenojejunal end, and this has to be done very close to the cirrus of the duodenum. This is done using the sharp dissection, and it may sometimes it can extend and it can involve the ileum, jejunum, and sometimes even extend to the gallbladder and liver. So after releasing the extrinsic obstruction, we have to rule out the intrinsic obstruction and pass an NG tube or in a catheter through the gastrostomy if it is present, and through the duodenum into the jejunum to rule out the intrinsic obstruction in the duodenum. So
Gastrostomy तो भी पूरी कुरान का ही डिस्क्राइब कर रहे हो मोस्टली gastrostomy कहाँ से आ रहा है?
She's saying that's what it is.
if it is-
Make a gastroscopy.
If there is a associated duodenal obstruction, right? The gas.
Gastrotomy करके
Gastrotomy.
allow the ex- okay.
Gastronomy करना पड़ेगा. Not
Not
gastroscopy.
gastrostomy. So after releasing the peritoneal bands, the duodenum will become straight downward and along the course of the right abdominal gutter, as we can see. This was the peritoneal bands, and after releasing, the duodenum is becoming straighter. And the pedicle of the mesentery can be dissected to broaden the base. However, the vascularity has to be taken in, the vessels has to be taken care. And however, we should not stabilize the mesentery, and that is not required in the surgery. So appendectomy can be done, and some of the appendectomy has to be done to avoid the future confusion in the diagnosis of the appendicitis. So some people propagate inversion ligation of the inversion ligation appendectomy to avoid the contamination. So the cecum will be then after the once the bands has been released, the cecum has to be placed in the left lower quadrant, and and we have to ensure the maximally widened mesentery, and the small intestine will go towards the right side of the abdomen, as the position has been as if this is the position which is present in the non-rotation status. Coming to the intestinal resection and the role of the second look procedures in the patients with volvulus. So whenever the patients present with the volvulus, depending on the duration and the type of the symptom, there can be development of the bowel ischemia, and sometimes it might require resection and anastomosis as well. So if the level of the ischemia, if the length of the ischemia is more, and which can lead to the short bowel syndrome, the second look laparotomy has to be considered, and especially if there is multiple areas of bowel with the questionable viability, or if the entire midgut appears non-viable, or if there is clinical signs and symptoms which are suggestive of progressive loss of the intestine, where the resection and anastomosis cannot be performed, the second look laparotomy has to be considered. So there is some role of administering low molecular weight dextrin, which can help in the improvement of the bowel viability as well. So the second look laparotomy is usually performed 12 to 24 hours after the surgery, after the first surgery, until the demarcation becomes very obvious and the surgery can be carried out. So some of the things that has to be kept in mind while operating includes, we have to preserve the minimum length of the intestine that is required for survival, particularly terminal ileum and IC wall, which helps in the majority of the absorption.
If you try, have to do necrotic and आपने डालनी पड़े.
This can be done rather than second dose and extra. Which is very negative.
After the derotation, we have to keep the heart
total member is there. Is anything else is there?
we can keep the hot pads, and we can warm the bowel and see if the
We have to do all things, something it's anyhow. Here something else. Yes. massage. Yeah, that is. And what they do before doing the something given I will. What is given for what resolution? What is this?
It is.
Yeah, they are. Yes.
Multiplays and
Availability, but that is a despair because the new units of the manager will understand what it is. We leave that and then what? There. That is quite popular nowadays. Very good picture nowadays. We want this before and after. It's very good. When we get to this level, assuming get the idea and describe it. And, it's I mean, it's a baby, still.
And we have to avoid anastomosis whenever there is questionable viability of the intestine, and the resection of the entire midgut, if required, it will necessitate lifelong TPN or small intestinal transplantation. So now coming to the atypical malrotation, sort of malrotation variant. So as we can see, if the DJ, if it is present in the towards the right side of the spine, it is a typical malrotation. But if it is present towards the left side, but it below the towards the midline, or if it is present in the left side below the level of the gastric outlet, these patients will have atypical malrotation. So the diagnosis is increasing these days by the radiologists whenever their patients are being worked up for the GER. So the dilemma exists whether to operate these patients or for the conservative management. So the risk of operating is that the patients who are presenting with the symptoms of recurrent abdominal pain and vomiting. So after surgery, they can have even higher symptom increase in the symptoms, or they can be the morbidity of the surgery and postoperative complications are much more higher when compared to the patients with a typical malrotation. So, and also these patients are less likely to have volvulus or internal hernias in the future. So the surgery has to be discussed with the family, and if the parents want surgery, then only the surgery has to be planned. Otherwise, the surgery can be avoided in these patients. Coming to the chronic obstruction, secondary to the reverse rotation and cecal volvulus. So these are the patients who present towards the later in the life, that is in the adulthood, and in the patients who present with the chronic obstruction of the colon. So initially the surgery was for the resection and anastomosis. However, now now the recent thought process is that if we free the duodenum and the underlying mesenteric vessels anteriorly and laterally of the transverse colon, this will release the obstruction and they will not really need further surgery. Coming to the cecal volvulus, these patients usually present with the obstruction, and here the reduction of the cecal volvulus without the fixation or cecostomy has to be done. Coming to the patients with the mesocolic hernia, so who present with the right mesocolic hernia, so this we have to incise the lateral peritoneal reflection of the right colon and rotate the colon towards the left side and free the intestine and reduce the hernia. So the key to the repair and reduction is the mobilize and towards the left mesocolic hernia. So the similar thing has to be done, and along with that, the key to the repair and the reduction is that we have to mobilize the inferior mesenteric vein, which forms the right border of the hernia sac of the hernia sac. So here the incision has to be. So towards the right left side, the right border is formed by the inferior mesenteric vein. So that has to be mobilized when we are reducing the hernia on the left side.
Left side will reduce the power from the right side will due to
we have to release the lateral peritoneal reflection and rotate this thing towards the. So the right side, the herniation is towards the, as in here there will be malrotation will be there on the right side and will be there. And so here the herniation of the bowel sac will be towards the lateral, and then lateral to the colon. So here. As in,
In simple terms, if you have a right mandible hernia, you can do an operation like mal, do all those things. So you keep the colon in the positions like you put in a mal operation. As I was saying, if you are left mandible hernia, you reduce all the contents in that problem, and then you have defect. And you can decide what to do. So you can use the defect in the non-external suture. So then avoid it in the back. Or we can reflect this beneath texture and reform it. This is not very standard, but you can get surprises. When you open an environment, there is a visible hernia and you don't know what. The right side of the number, you know, like a malrotation. Left side, reduce and close it.
So for the whole exercise, this is better to open.
You see,
then we have sac. The bubble, this small bubble will be herniating towards through the mesocolon.
Yeah, yeah. Payment points. Small amount. Here that we have to check.
you see mesocolon, and most of the small bowel will be behind these. Small bowel will not be seen directly as you see on the. Will be covered by a thin transparent sheet, which is actually mesocolon.
It's a kind of emergency, but actually.
In older patients, you can't see anything. In older patient, because of chronic inflammation, even the mesocolon is thick and yellow because of fat. You can't see. You see only the large gut and a bulge behind the.
Now coming to the employing the minimal invasive surgery in the patients with malrotation. So it was first reported in 1995. So the laparoscopic minimal invasive surgery can be employed in the patients with malrotation to diagnose and as well as correct the malrotation. However, the feasibility of the LATS procedure using the laparoscopic approach is debated, especially in the patients with the in the patients of neonate and those who present with the midgut volvulus because of the limited working space. In a study done by Shalabre et al. In 2020, they found that the laparoscopic surgery can be employed and it is feasible, including in the even in the patients who present with malrotation in midgut volvulus, and they had a shorter hospital stay as well as a shorter time to reach full feed. However, in these patients, there was a selection bias at the in this study since they employed laparoscopic surgery only in the patients of elective patients and not in the patients who present to the emergency. So this is the normal port position for the midgut volvulus, and this is the place of interest, that is the duodenum, and here we will be placing the ports to do the LATS procedure. So hence in the patients who present with midgut volvulus, there can be difficulty in operating the patients, and as well as in the patients who are having the bowel ischemia, the handling of the bowel can be difficult when we are doing the minimal invasive surgery. So the patient selection is very important when we are employing the minimal invasive surgery for laparoscopic surgery for malrotation. So in the patients who are hemodynamically stable and who are diagnosed earlier, can be selected for the laparoscopic surgery. However, the conversion rate is high as 25%. So the laparoscopy causes, there is another theory that the laparoscopy causes fewer post-operative adhesions, which can increase the risk of post-operative volvulus in the patients of malrotation. However, it is only a theoretical risk and it is not, it is yet to be studied. So in a meta-analysis by Kitania et al., they found that the post-operative volvulus was 3.5% following laparoscopy and it was 1.4% after the laparotomy. This is the recurrent volvulus which can occur in the patients of malrotation. So now coming to the other postoperative management and complications of the patients with malrotation. So the return to the return of the normal intestinal function, it can take some time depending on the presentation of the patient and the duration of the duration of the symptoms present prior to the surgery as well. So in the patients who are presenting with uncomplicated cases and they have only minimal extrinsic obstruction, the peristalsis usually returns within 1 to 5 days, and we can start the feeds by 5 days, and there is no need for any decompression of the stomach. However, if the patient is presenting with a chronic malrotation, or if there is evidence of chronic obstruction or volvulus, we can expect prolonged IS in these patients, and these patients might require decompression of the stomach as per the need. Coming to the marginally viable bowel, coming to the other patients who are presenting with the acute midgut volvulus with the short bowel syndrome, or if the patient is having some amount of mucosal injury, these patients might require TPN or until the adaptation and compensatory growth of the residual bowel can occur. So the small amount of enteral nutrition has to be given in these patients as well to encourage the adaptation of the bowel. Coming to the complications like post-operative intussusception, the rate of post-operative intussusception is higher in the patients with the malrotation when compared to the patients of other laparotomies. And coming to the adhesive intestinal obstruction in the patients of malrotation, it is up to 4%, which is almost equivalent to the other laparotomies. The incidence of recurrent volvulus is low. However, there is a theoretical high risk for recurrent volvulus in the patients who have undergone a laparoscopic correction. So coming to the death, mortality is usually not there, but however, the patient presents with the later stage of midgut volvulus with the peritonitis, and if there is extensive intestinal necrosis, there can be death in these patients, or it can be related to the nutritional complications, or if the patient is dependent on the parenteral nutrition, it can be, and the death can be because of the sepsis and catheter related or other nutritional complications. To conclude the presentations, so as we studied, the normal bowel rotation happen in the normal bowel rotation, there are two loops: proximal duodenal jejunal loop and the distal cecocolic loop. So both of them rotate in the counterclockwise direction by 270 to assume the normal position in the normal embryology. This happens during the 4th to 12th week of gestation. And if it doesn't occur normally, there are 3 types of malrotation which can occur. One is a non-rotation, and the other one is the incomplete rotation and reverse rotation. So the clinical manifestation can vary depending on the type of, depending on the patient and results.
Normally, what malrotation do we see?
So normally we see the incomplete rotations because
What do you look for non-rotation?
non-rotation, if they present, even these non-rotation patients can have, they have a high risk for midgut volvulus. Unless they present with the symptoms, we do not operate non-rotation patients.
Non-rotation is not considered to be having a higher risk.
But because of the
present in these conditions, what are the conditions in which we see non-rotation?
in the CDH and non-spirosis, these are the
So now,
patients.
previously people used to operate for these patients, that used to correct this rotation anomalies also. Nowadays, we're not doing, because we consider it is not a significantly high risk of volvulus.
But because of the short mesenteric pedicle, narrow pedicle of the mesentery, they can have increased risk of midgut volvulus even in the non-rotation patients.
So non-rotation की position क्या होगी आपकी?
The
Non-rotation में जो position होगी, it will be the same in which you place after correcting the malrotation. So why will it have a higher risk? Okay. When you correct the malrotation and place the bowel, you place the bowel in the position of non-rotation. Theoretically, there should not be higher risk. The volvulus, even then, it do occur in these patients. They occur because, you know, in the what we see this abdominal wall defects and CDH, some adhesions and other things are also there. So loops get entangled and they rotate on its axis. That increases the risk. But as such, if a classic non-rotation is there, there should not be a higher risk of volvulus. Okay, अगर और कुछ तुम्हें लिटरेचर मिलता है तो let me know.
So majority of the patients, that is up to 80% of the patients will present in the neonatal age group. However, they can be patient presenting in the later age group with the failure to thrive and recurrent episodes of pain, abdomen and vomiting. So the diagnosis is based on the history, physical examination and radiological investigations, including the upper GI contrast study, and we can employ the screening USG as well. So when the patients present with the acute abdomen, appropriate preoperative resuscitation has to be done, followed by the LADS procedure, which includes the 6 major steps. One is the evisceration of the bowel and inspection of the mesenteric root for the volvulus. If the volvulus is present, counterclockwise derotation of the midgut volvulus has to be done, lysis of the LADS peritoneal band and straightening of the duodenum, and appendectomy and placement of the cecum in the left left lower quadrant and the small intestine in the right lower quadrant. The laparoscopic LADS procedure can be employed in the selected patients who are hemodynamically stable and who do not present with the acute abdomen. Post-operative outcome, there is a risk of adhesive adhesion formation as well as the risk of recurrent volvulus formation. However, the incidence is very low. Thank you.
Just a quick recap. Three main presentation categories for malnutrition.
The type of malnutrition,
Presentation.
presentation. So one is that they can present with the recurrent, one is the acute abdomen, which is acute midgut volvulus. Yes. And the recurrent bilious vomiting in the neonatal age. Yes. Duodenal obstruction.
Third,
And the chronic volvulus, which can present later.
midgut can be acute or chronic and failure. Third is
Mesothelioma.
These are the three main. And you rightly pointed out that UGI studies are generally considered the gold standards. Recently, ultrasonography are coming in a big way. So what are the ultrasonography findings? Because they are claiming ultrasound has the sensitivity of